Good afternoon, students. I hope you are enjoying or trying to enjoy your Labor Day holiday. This is your recorded lecture, so make sure that you go through it very carefully because these items are going to be seen again on the exam. Couple of reminders for you guys. You have a Canvas quiz that is going to be due for the senses and the reproductive system, which is what we're going to cover today. I will start with the senses first. But your Canvas quiz is going to be due on Saturday at 11:50 p.m. Alrighty, so let's start with the senses, ladies and gents. And these are your objectives, which we're going to cover today, so you can review those at your leisure. Okay? Alrighty, so let's go ahead and talk a little bit about the classification of our sense organs. We have general sense organs, and then we have those specialized sense organs. The specialized sense organs are the ones that you normally think of when you're referring or think about sense organs. So that's going to be the organs that we utilize for smell, organs that we utilize for taste, for vision, for hearing, maintaining equilibrium, and then to a certain extent, well, I don't really want to say feeling because that's more so going to go into those generalized sense organs. And in your generalized sense organs, you have these microscopic receptors all over your skin. They're located throughout your body. And what they do is they kind of give you information about the outside or external environment around you, which is what your organs, which is what your senses are supposed to do. They're supposed to give you information about the external environment. So your general senses are going to do exactly that. Located throughout your body, that's going to include your skin, your muscles, your tendons, and your internal organs. And they are responsible for things like pain and things like temperature, touch, and pressure. If you ever have experienced, say, a haunted house, that's what I like to use, and it's completely dark, or even if you're in a strange location and it's dark, have you ever had a sense or a feeling that someone might be near you or something might be impending? Not necessarily impending, but you know that something is necessarily near you. That's where your generalized sense organs are going to come in. And your skin is going to start to tingle, or you may perhaps kind of feel like a chill. And what that does is that lets your body know that something external to you is informing you and giving you information about your external environment. Okay, so now I want to talk about how your body converts a form of stimulus to a sensation. So, in order for you to tell a sensation, like a sensation would be something like a smell or a sight or a feeling or something, you have to be able to detect that stimulus. So that means that your neurologic system must be intact. Now, if you have a neurologic system that's not intact because maybe your patient has had a stroke or maybe even a vertebral tear or vertebral disruption, then they're not going to be able to detect any stimulus that comes into the senses. And when I refer to stimulus, I mean things like things that come into your body and you can sense those feelings, or if it comes into your smell, into your nose and you can smell these things, or sight, or any of those sense organs. You also must be able to detect changes in your environment. And the way that we detect changes in our environment is the utilization of all of our senses. So we can tell if something smells funky or doesn't smell right, that's a change in our environment. If it's cold outside, or if it's warm outside, either we're going to begin to shiver. If it's cold outside, if it's warm outside, we may begin to perspirate. So that lets us know that there are changes in our environment. In order, stimulus must be changed into a nerve impulse. So in other words, for example, if you were to prick someone with a pin, the stimulus is going to be the pin. Your neurologic system must be intact in order for you to feel that sensation. And what happens is that pin prick is going to send an innervation impulse or a nerve impulse throughout the body, throughout that generalized sense organs, up to your brain to let you know that you have been pricked so that you can actually feel that form of stimulus, okay? Those signals from, say, the skin of where the pin prick occurred, up to the muscles, up to the spinal cord, up to the brain, are transmitted over a pathway. So that's going to be the pathway. It'll be from the skin itself, and all of this goes from skin to the nervous system. The nervous system has, and we'll talk more so about that when we cover neurology. Your nerves are throughout all your entire skin, and all of your muscles are completely innervated. They have a lot of nerve endings. So if you were to do that pinprick, That nerve is going to be stimulated. It's going to move up the arm, for example. It's going to hit um, into the spinal cord at wherever the location is at the pinprick, and then goes up to the brain and lets the brain know that the sensation occurs. So the pinprick has occurred. So that may cause the person to maybe pull away from it, scream, ouch, maybe shake their finger, but that signal is being transmitted across that pathway. Okay. All right. So we did talk a little bit about those generalized sense organs. And they're found throughout the body system. They're more concentrated on the skin because that's how you're going to interact with your environment. But they don't respond to the same types of stimulus. So it really depends on how intact your nervous system is, how intact those pathways are, and your individual ability to sense stimuli. So for example, sometimes if you have patients that may have a little bit of neurologic damage, or maybe you're a little on the older side, if you have a geriatric patient, if you rub their skin with a feather, they may not be able to feel it. But if someone who's in their 20s can immediately feel it because they're more sensitive to those sense organs themselves. And it allows you to differentiate between different stimulus. So as nurses, when you're doing your assessments, and you're trying to determine neurological intactment, it gives you an idea if you use something maybe sharp versus something blunt to kind of determine how well that particular patient is able to differentiate between two stimuli. Okay. All righty. So let's talk about more so now the specialized. Now we're going to go into your hearing, your sight, your nose, and your taste buds. All right. So the first one I want to cover are the eyes themselves. Okay. And as we know, the eyes are utilized for sight. But let me just kind of break down some of those individual parts of the eye. Okay. The sclera of the eyes, the first part we'll talk about, it is the largest part. It is the white of the eye. Okay. And it is covered by the cornea. So the cornea is on the front part of the sclera. It is the outermost surface. It is what protects the inner portion of the front part of the eye. And then we have the conjunctiva. So if you were to say pull your lower lid down or up, I don't know if you guys were crazy kids like when I was a kid a bunch of years ago. We used to flip the top of our eyelids inside out to scare the daylights out of everyone. That inside of that eye, that pinkish, whitish, light reddish area is called the conjunctiva. It is the mucous membrane that covers the eye. I'll say that again. It's important. The conjunctiva is the mucous membrane that causes the eye. If it gets infected, the patient may have a disorder called conjunctivitis, which is a fancy word for saying pink eye. So you see that a lot of times in children because they're not necessarily the most hygienic. They don't wash their hands as frequently as they should or as well as they should. And the first thing, if they get any kind of debris in their eye or allergies, they're going to rub them. So that's why kids are more predisposed to developing conjunctivitis. Next, we have the cornea itself. Okay, we talked a little bit about the cornea already, with being the outer surface. If the cornea itself gets inflamed, that is called keratinitis. And what may happen if a patient has developed conjunctivitis, or that inflammation or infection of the conjunctiva, that eyelid is going to constantly be rubbing on the cornea. So if you have untreated conjunctivitis, it can migrate into keratinitis, where you will have inflammation of the cornea. Now, this can be exceptionally serious because sometimes keratinitis is difficult to treat because the cornea itself does not have any blood vessels. So if you put antibiotics in it, it's a little difficult to treat because there's no blood vessels in order for it to circulate around. But we can give topical antibiotics that help to kind of work and get rid of that keratinitis. Sometimes if the cornea is scratched, like from an eye injury, if a person gets hit in the eye, maybe a car accident and debris gets into the cornea itself, or sunglasses breaks or glasses break, so they get hit in the eye with something blunt and sharp, it can cause keratinitis. Alrighty. Then we have the iris of the eye, which is the colored part of the eye, which gives you, your patient their eye color. I'll move on to the lacrimal gland. The lacrimal gland, if you lower the inner portion of your eye, you may see that little hole in your eye. That lacrimal gland, ladies and gents, is where tears form, okay? It also kind of drains into the blood system. So it is a great location for us to put eye medications because, it's very moist, it's very lubricated, so we can spread eye medications around, but you have to be exceptionally careful if you have a medication that you need to apply to the eye and you do not want it to become systemic. So for example, if you have a patient that has, say, glaucoma, and we'll talk more so about this in med-surg, in glaucoma, the eye itself has a lot of pressure, has a lot of buildup of pressure, which is why patients have difficulty with their eyesight. We prescribe a medication called beta blockers, which we'll talk about in a couple of weeks. And beta blockers have a tendency to dilate vessels and open up, dilate vessels, which therefore lowers blood pressure. Now, if you have a patient that already has a low blood pressure, you don't want that medication to get into the bloodstream. So anytime that we administer like glaucoma medications, because they have that side effect if they get into the blood system that they'll lower the blood pressure, we have to occlude that lacrimal gland and just apply a little bit of pressure so that it does not become systemic. And I'll move on to conjunctivitis, which we talked a little bit about. That is the inflammation of the conjunctiva itself. It can be bacterial or viral in nature. If it is bacterial in nature, which is the least common, we can give our kiddos, usually it's kiddos, but if adults get pink eye as well, but we can give our kiddos antibacterial ointment. And to put into the eye, you put a small thin layer in the conjunctiva and have them blink a couple of times, smear it all around their eyes, and just let it sit for a bit with their eyes closed. Now, I'll be honest, sometimes it can burn just a tad, but that's what we utilize for bacterial conjunctivitis. In viruses, antibiotics do not work. Usually we do not give anything for viral infections because they are self-limiting, which means that you have to kind of let them go on their own. You got to allow the body's natural ability to fight it, which is why COVID is so difficult to fight right now, because our bodies just are not equipped to deal with such a foreign virus. But in conjunctivitis, most times when kiddos have it, it is viral in nature. You just keep the eye clean. Don't have them touch it. Keep their hands nice and clean. If they need to rub, use a tissue and just use the one wipe and throw the tissue away, another wipe and throw a tissue away. Don't reuse tissues. And usually when it's viral conjunctivitis, it'll go away on its own. We don't make a big deal. We just keep them separated from the family and let them have at it. Now we'll move into the middle layer of the eye, which is called the choroid, and it does contain a bit of dark pigment, okay? We have the pupil of the eye. The pupil is like an aperture of a camera that closes and opens. It accommodates for light. So for example, if you're in a dark area, the pupil is going to open up a lot wider because it wants to allow as much light in as humanly possible so that you can see. If you're out in the sun and you're sunbathing, you're at the beach, it's going to close as much as it can so that it can eliminate that much light coming in. So like I said, it acts as an aperture of a camera. And then we have the lens. Now the lens is going to sit behind the pupil, and the lens allows us to focus. Now normally it's going to sit at a specific spot that allows for perfect vision. It sits at a certain spot that allows for perfect vision. But unfortunately, sometimes people become nearsighted or farsighted, or born nearsighted or farsighted. Presbyopia is farsightedness. So that means that these individuals can see far away, but when it comes to reading a book, they have a little bit difficulty reading those books. Myopia is nearsightedness, so they can read books, but they can't see very far for driving. So they're going to have to, wear glasses to adjust. And what the glasses ideally do is, remember when I said that point of refraction where that place is like a kind of like, and you probably will see it in your book, it's a point where light has to hit the retina of the eye itself, okay? Has to hit it pinpoint. But unfortunately, if that lens is either ahead or behind the retina, it's going to make the difference whether your patient is going to be nearsighted or farsighted. Eyeglasses are designed to focus that particular refractory point or refraction point directly in where it's supposed to be at that retina. So that's how it corrects the accommodation, okay? Lastly, we have cataracts, and cataracts occurs in our older patients. The outer ring of the eye takes on a milky white or milky gray appearance, and it doesn't have as much transparency. So what happens is the patient may begin to see small halos around their eyes because it builds up with that milky transparency within the eye, not transparency, but opaqueness in the eye itself. It's really simple to fix. Usually the docs will go ahead and knock it out, give a little cut to the cornea itself, drain it on out. It usually seals on it up on its own. They'll put a little anti-inflammatory drops in there, and then let the patient go about their business. Okay, now I want to talk a little bit about the retina. The retina is the innermost portion of the eye. It sits toward the back. And within the retina, you have specialized cells that are called rods and cones. Now, rods are utilized and are useful when seeing and when you need to see dim light. So once again, rods are useful when you need to see in dim light. So when it's dark outside or you're driving at night, it is going to be your rods that are going to be utilized to focus on things that you need to see. Cones are utilized to help you focus in bright light. Okay, so rods are for dark and cones are for light. The part of the retina called the fovea centralis, the fovea centralis, and in the fovea centralis, that is the highest concentration of cones. So we utilize that fovea centralis when we're looking at very bright objects, sun, things like that. So you have to protect that area, and we protect that by applying really high UV reflective sunglasses. So if you're someone that constantly stays out in the light, or you do a lot of day driving, long distance driving, and the sun is coming right on right in your face, you want to definitely make sure that you have good quality UV sunglasses so that you don't necessarily mess up that area. And then in the back of the retina, we have two areas, the aqueous and the vitreous humor. The aqueous humor sits toward the front, and it has like a fluid to it, and it keeps the inner portion of the eye nice and liquidy. It also allows us to help with refraction of light, because water or fluid acts kind of like a mirror or a glass, like a picture glass. So we have that aqueous humor. Toward the back, we have the vitreous humor, which is a little thicker. It's more so in the back of the eyeball, and it's going to be a little bit thicker. That vitreous humor is the fluid. Remember I mentioned in when I was talking a little bit about glaucoma. In glaucoma, there is a certain amount of pressure that belongs in that vitreous area. If that vitreous area begins to increase in pressure, and a lot of times the vitreous humor and aqueous humor normally has to drain back into circulation. So it keeps a certain level of fluid going in both areas, but a certain amount of it does have to flow out. If those areas where it flows out becomes impeded, or the vessels become closed because of, say, high blood pressure, kidney disease, things like that, the fluid cannot drain back out of the back into the blood system. So therefore, it builds up, and our patients will develop what we call intraocular pressure. Intraocular pressure is measured if you've ever gone to the eye doctor and they kind of look in the back of your eye. They have all those little crazy machines, and you'll look in one of the little machines and it might have like a house, and they'll tell you to focus so that they can look in the back of the eye. They're normally measuring intraocular pressure. So when a patient does develop an increase in intraocular pressure, they have glaucoma. The way that we lower that is that we give a blood pressure medication, usually to the eye, to open up those vessels, and that's going to promote the outflow of fluid back into the blood system. Alrighty, and then we have the visual pathway. And the visual pathway, I believe there's a picture in your book. The way that our body visualizes an object, we normally, when it enters into the eye, it comes in right side up. The brain has to invert it upside down through those particular refractory pathways in order for you to identify what that particular object is. Okay. Now we also have photoreceptor cells within that pathway, and they're utilized to identify, to help. They work along with those rods and cones to identify lights as well. Then right behind that refractory pathway, that little point where it meets, remember I said it mentions where the lens is going to place the object directly on that refraction point. Right behind that is the optic disc, and the optic disc is known as the blind spot of our brain, of our eyes, the blind spot. Lastly, our eyes utilize three pairs of muscles. I don't care if you know them, but there are three pairs of muscles that we utilize to move our eyes, to move them from left to right, up and down, and to close our eyelids themselves. Okay, now I'll move on to the ear. To the ear. And the purpose of the ear is for, well, the ear has two purposes. Of course, for hearing. It's how we hear and interact auditorily with our environment. And also the ear plays a role in our balance or equilibrium. The way that we hear is that whatever particular item gives off sound, it vibrates waves in the air itself, and that causes fluid in our ear to vibrate itself. That information is in turn sent to the brain and then interpreted as a sound. So let's talk a little bit about the ear itself. On the outside, we have the external portion of the ear. Okay, we have the outside, which is the auricle or the pinna, and the pinna of the ear is going to be where your earrings are, the lower portion of your ear. Auricle is going to be the top. Then inside, a little further in, we have the tympanic membrane or your eardrum. And your eardrum is going to be where that's the division between the external ear and the middle ear. Within the external portion of the ear, we have several ceruminous glands. And in those ceruminous glands, that's where earwax is created. And earwax, another word for earwax, is going to be a cerumen. Then we have the middle ear, and within the middle ear, ladies and gents, there are two tiny bones. These are the smallest bones in the human body: the malleus, the incus, and the stapes. Okay? Actually, that's not staples, that should be stapes. Sorry, guys. S-T-A-P-E-S. So once again, we have the malleus, the incus, and the stapes that exist inside of the middle ear. You also have eustachian tubes that connect the throat to the middle ear. In children, the eustachian tube is relatively lateral. It sits horizontally. It's very straight, which is why children, unfortunately, have a tendency of getting middle ear infections more readily than adults. So as a person ages, that eustachian tube begins to kind of bend more so at a 90, well, not quite a 90, more like a 100 and 120 degree angle, but it begins to angle itself, whereas in children, it's a straight line going across. So when you have children, especially when they're sleeping or say that they're, not feeling so well and they're putting things in their mouths or they're sleeping and drool begins to kind of slide down their face into their ears, unfortunately, within the mouth there are a lot of staphylococcus bacteria that exists, and that staph from the drool happens to go into their ear and ultimately can cause them to have ear infections. Okay. Also, as little kids, they tend to put things in their mouths, and the same thing applies. So that eustachian tube is connected directly to the throat, which predisposes smaller patients to middle ear infections more readily than adults. Otitis media is just another word for a middle ear infection. And the oval window exists in the middle ear, and it separates the middle ear from the inner ear. Okay, so now let's go a little further in the ear. Within the inner ear, we have the bony labyrinth, and the bony labyrinth is a complex maze of tissues, and it divided into the vestibule, the semicircular canals, and the cochlear. So once again, the bony labyrinth is a complex maze of tissues, and it is in turn divided by three different areas: the vestibule of the ear, the semicircular canals of the ear, and the cochlear. Okay? The vestibule is the site of balance. The vestibule is the site of balance. It's where balance is registered. So if a patient has an inner ear infection and it migrates past into the bony labyrinth and can get into the vestibule, if it's untreated, really serious purulent, strong staphylococcal infection, it can cause usually children, it's not really so much adults, but it can cause children to go into, to have issues with their balance if it's untreated. Okay. What else did I want to say? Also, we'll just skip a little bit. The cochlear, well, let's skip a little bit. The organ of Corti, which is a very important organ, it is the actual site and registration of hearing. It is the actual site and organ of hearing. So the organ of Corti is what's going to vibrate. I mean, with the assistance, of course, with the malleus, the incus, and the stapes. But the organ of Corti is going to be the actual organ of hearing. So let me just kind of show you a picture so you can kind of see what I'm talking about, okay? So remember we discussed the eustachian tube. Now here we're talking the auditory tube, eustachian tube, exactly the same. So if you were to see in this area, this is an adult. Because if we look at the ear canal and then the eustachian tube, as you see, it kind of makes like a 120 or so angle. So if a cootie were to come in the ear here, okay? So let's pretend, like I said, this is the person, this is the ear canal, this is our eustachian tube or auditory tube. And then this further goes in and connects into the throat. So if we have an adult, if they were to say, you know, rub their ear with a dirty finger, or they were to, kind of drivel in their sleep, if it were to get into the ear, well, we have this area right here. It doesn't go directly into the eustachian tube. So if that gets into that ear and this tympanic membrane, hopefully as an adult, you know, you'll be able to fight that bacteria. But in little people, this particular eustachian tube in our children goes straight across right here. So if it goes straight across right here, if there is a virulent bacteria that goes in, it can go directly into the throat itself, therefore causing an upper respiratory infection. So here, guys, you can kind of see them. I know it's not the clearest picture. You have the malleus, you have the incus, and the stapes here. And the stapes sits right here within the oval window. These three teeny tiny bones are going to vibrate, and they also assist in being able to hear. So when sound waves come in, these things are going to migrate and move, and then ultimately create those sound waves within the inside of the body so that the patient or the person can hear. Let's move on to taste, ladies and gents. Within taste, we have taste buds, okay? We have taste buds. And on those taste buds, you'll probably see these little tiny bumps on your tongues. Those are called papillae. And the reason that we have papillae and they're being raised is that they cause more available surface area. So if the tongue was absolutely smooth, you would be able to taste less versus having those raised areas of those papillae, which allow you to taste the more robust foods, okay? Your gustatory cells, ladies and gents, very important, your gustatory cells are responsible for the sense of taste. Your gustatory cells are responsible for you being able to taste your food. So let's discuss the primary taste senses. And I know when you were in school, in grade school, elementary school, you probably learned that there were certain areas of the tongue that taste certain kinds of tastes. Not true, not true. You taste everywhere throughout your tongue, okay? So I don't want you to think, like, I know they used to have a little map and it would say maybe sweet was here and then salty were here. Now that's no longer so. You taste all of those tastes all over your tongue. And these are the primary sense of taste. Sweets, which you can pick up, like, candies, chocolates, things like that. Salty, of course, is going to be, your crackers, your saltines, your pretzels, potato chips, okay? Metallic-y taste. Sometimes you may get a metallic-y taste. The most common times that I've seen it is a side effect of medications. It can give you really a metally taste, like you've been chewing on a spoon or something, a metally taste in your mouth. And then you have bitter and sour, which comes along those lines with maybe like a bitter candy or even a sour lemon. Within the recent years in Japan, they have determined that there is a final taste sense that is available, and it's called umami. And umami, it has a more of a beefy taste. It kind of I can't really describe it because I can't say that I've experienced it, but I understand what they're saying. It's more of a robust, meaty taste, mostly found in like beefs and porks and things like that you would recommend. that you would experience rather. And then we have the sense of smell and our smell receptors located in our nose. Now, one thing I did want to point out, smelling is not something that just occurs. For example, hearing, if there's a noise that emits, you can't help but hear it. If something passes your vision, you cannot help but see it. But in smell, you have to forcefully smell. So if there's something that maybe smells a little rancid in your refrigerator, if you don't take a good whiff in on purpose, then you won't smell it. Now sometimes you don't necessarily have to say, let me take a good whiff and get that good smell in. No. But just to let you know, normally for smelling, you do have to forcefully take a good breath in order to smell. Okay? The way that smell works is that chemicals must be dissolved into the air and then in turn hit the mucous membrane of the nasal cavity in order for you to smell. Although it's sensitive, they easily adapt. And smells also, guys, are related to memory. That's a wonderful thing about smells. So if you remember maybe when you were a kid, if your grandma or your grandfather might have cooked a certain meal, or a certain dessert or wonderful food that you enjoyed, the moment that you smell something that smells similar to that, or a person may have worn a wonderful cologne or perfume, it does bring you memories. It brings you memories of that particular person. Okay. The reason that smell is so ingrained in our memory is that it is done by the limbic part of our brain. So that smell is registered in the limbic, and we'll talk more so about that when we cover neuro, the limbic portion of the brain, and also that's where memories are stored. So once again, that limbic part of the brain is responsible for registering smells, and also memories are stored there. So that's where you get that wonderful correlation where smells bring back those level of memories for you. Okay, so that's it for senses, ladies and gents. I'm going to move on to repro, and we'll do that in another video. Thank you very much.